So alcohol use disorder, previous to 2013, previous to the latest edition of the DSM, operated along two separate definitions that included alcohol abuse and alcohol dependence, right? So abuse and dependence. It was thought that dependence was a more severe form of abuse. That was a general idea. For purposes of diagnosis, the individual only required a single criterion to be diagnosed with alcohol abuse, three for alcohol dependence. In 2013, the American Psychiatric Association decided to combine the two sets of criteria and come up with one overriding illness called alcohol use disorder. They took the average, and an individual only requires two from the list. Of course, this whole time, the individual must demonstrate some functional impairment, and that is critically important to understand because in no part of the definition does it ever talk about quantity, or frequency for that matter. So if an individual actually fits diagnostic criteria, if you are discussing with them your medical opinion that they are afflicted with alcohol use disorder, a reaction of, I don't drink every day, or when I drink, I only drink X amount, or I only drink beer, right, which is an allusion to alcohol by content or proof. None of that matters. And the clinician must understand that. And more importantly, the clinician must convey that understanding and therefore their concern to the person they're caring for. Right? So that's alcohol use disorder. Some of the behaviors would include use of the substance during conditions when it is physically hazardous, interpersonal dysfunction as a result of the use of a substance, continued or persisting use despite knowledge of adverse consequences. So those are some brief examples. There are several others of which the individual is only required two. And having said all this now, you can simply substitute any other substance for alcohol here and then come up with blank use disorder, right? So this is not specific to alcohol. Any substance or toxin can be substituted here. Person comes in, we'll call him the assistant. I'd have to look up the cast as well to actually know the name, so shame on me. Patient comes in for a chief complaint of blank, the severity of which results in your admitting them to the hospital. Because you have provided a screening exam, specifically the CAGE questions, you believe that you've screened positive, then you go to the structured clinical interview. That's nothing more than the DSM criteria, and then you diagnose alcohol use disorder. You discuss the diagnosis with your patient, now that you are rounding with him or her as an inpatient attending. On hospital day number 3, and that's important to recognize because that is the pathognomonic day of hospitalization that this occurs, the patient goes into alcohol withdrawal. Alcohol withdrawal is a set of signs and symptoms that results from the absolute or relative cessation of a substance, in this case, alcohol. Treatment of which will be to simply substitute, and sometimes not so simply, substitute a medication with a similar mechanism of action to alcohol, albeit with a longer half-life, to address the physiologic signs of alcohol withdrawal. We'll stop there. I don't want to get into any more details because there is another film that we're going to discuss pertaining to the use of alcohol. I want this discussion, today's discussion on Sleeping Beauty, to be focused on the substance that I believe that this particular Disney film exemplifies. So I did want to give you some brief background on alcohol, but even though there is a character in Sleeping Beauty afflicted with AUD, I don't think that the film is about AUD.
I'm wondering if it could be sort of a representation of catatonia.
How so?
Maybe a little bit more like metaphorical, because obviously, like, she's put to sleep by magic. But being in a state in which you are not speaking, not moving,
So if she arrived, talking about Aurora now, if she arrived to your care through maybe an emergency department, and she wouldn't be able to tell us, somebody, a collateral, would need to tell us about what precipitated the current behavior, which would be her being unresponsive. I am not sure whether or not the person telling us it was magic is going to have you kind of ignore the idea of catatonia. My guess as a clinician, you're probably going to still think catatonia.
Especially because of the preceding intense stressful factors of, one, finding out like your whole life has kind of been a lie, and two, being expected to move and take on all of these new responsibilities. It's a lot of stressful events happening in a teenage girl. And she's supposed to only be, I think, like 16 or 15 or something.
Yeah.
So,
mm-hmm. So the differential for catatonia is rather broad. Basically, we think medical / neurological versus other, and that's where psychiatric comes in. I don't know if we have right now a clear picture of the etiology of her unresponsiveness. Rule out catatonia. Catatonia operates, I think, with two separate definitions. One is a general one that is simply an individual who is unresponsive to their environment. So it's just a general definition of catatonia. The more specific definition begins with the DSM. I think you only need 2 or 3 criteria from a rather long list. I'll post this later on Instagram. It has nothing to do with the movie, and now that I think of it, I probably should look for a movie that does include a computer, because computer message is actually the acronym to remember the different diagnostic criteria. COMP message, computer message, abbreviated, actual diagnostic criteria, and you only need more than 2, right? So I am not going to be able to rattle off all of those criteria for you now, so don't even think of pimping me. Right, but a couple of thoughts here. I know that the other O is a cheat, because I needed something to fill the O in the acronym computer message. Other stands for echolalia and echopraxia. Right, so examples here, these could be mental status exam findings, findings of which may support a preliminary diagnosis of catatonia. Echolalia is when the individual, it's usually your patient, will repeat what the examiner is saying. Echopraxia is they're repeating or mimicking your behavior at bedside or elsewhere. Echopraxia. M stands for mannerisms. And the S stands for stereotypies. And I want to bring this up because there is a subtle difference between a mannerism and a stereotypy. Stereotypies are repetitive behaviors that are usually clinically described as nonsensical. That is, there really is zero goal-directed activity associated with a stereotypy. So headbanging, stereotypy. A mannerism's a little different in that a mannerism is defined as a seemingly purposeful act. Oh, I take it back. It's a seemingly purposeless act in the setting of a purposeful overall behavior. So again, a mannerism is a seemingly purposeless act in the context of an overriding goal-directed behavior. Anybody here ever watch I'm trying to think of a situational comedy. Raymond. Everybody loves Raymond. Thank you. Anybody familiar with that? The brother Robert? Anybody recognize or identify Robert's eating habits?
Yeah,
Right. It's a purposeless act in the setting of an overriding goal-directed behavior, which would be eating. Right. Robert has a mannerism. It's different. That's different from headbanging. Right. So a couple of examples with regard to catatonia. In a clinical setting, we go above and beyond the DSM definition, and we provide a structured assessment called the Bush-Francis Catatonia Scale, which has several more items than the DSM definition. The general practice with regard to assessing for catatonia in a hospital setting, for example, is to apply that Bush-Francis scale. You come up with a composite score, 20, let's say, to play with round numbers. Then you provide a 1 milligram intravenous dose of lorazepam. And anywhere between 5 and 30 minutes, you would expect to see a response defined as a reduction in the Bush-Francis score by 50%. That is diagnostic for catatonia. Unfortunately, there are false negatives. Unfortunately, there is a high rate of false negatives. So while response is diagnostic, non-response does not definitively rule out catatonia. If the prince is kiss, apostrophe S kiss, is metaphorical for an IV dose of lorazepam, maybe Aurora is in fact catatonic. Although we don't know the cause. We don't know. Now, malignant catatonia is a catatonic condition or situation in which the individual has additional signs and symptoms that themselves begin to hallmark a medical emergency. So labile blood pressure pulse would be an example. And in extreme cases, electroconvulsive therapy has been found to be efficacious. Any other thoughts, observations about Aurora?
Well, I was thinking like initially like a substance-induced state, I guess like it's evident by like the fairies kind of like sprinkling along the community. So like initially I was thinking like, well, she hadn't had an additional stimulus, like Aurora hadn't had like the pricking of the finger, but then like the whole community may have like a delirium or like a substance-induced, like maybe from like a long-acting benzo or something like that, like metaphorically.
So describe to me what you observed first in Aurora and then the community.
So Aurora was asleep and she woke up, and then I guess Maleficent came in the room. She turned green and she like it seemed like had like was responding to like internal stimuli, and then subsequently like pricked her finger. So it seemed like there were like command type like auditory hallucinations, I guess, that she was responding to.
She certainly went towards that needle in a trance-like state. So you're concerned that there may have been the direct physiologic effect of a substance.
Yeah.
Right. So for Aurora, and then what about the community?
Like maybe they had like some type of like poisoning or something as like by the fairy dust. Like maybe they had like a long-acting like sedative as well, like long-acting benzo. But there was something that universally affected the community, making them like delirious and or sedated.
So the entire community was sedated.
Yeah.
So I mean, when we see this happen, there's a couple of things that we should consider. Number one is whether or not what we're seeing is true, or are we seeing this through the eyes of one of the characters, right? Because it's hard to it becomes difficult to begin to formulate population health. In this case, population mental health. Of course, what we always fall back to is this condition of shared psychotic disorder. Is what is afflicting everyone, and may there have been an index case that could explain everyone else's behavior. Again, so it's a rather tough dynamic to sell. And then, of course, across this continuum would be that there's mass exposure to something, right? Like a toxin exposure is something in the drinking water. Right. Again, it would have to be something population-based for the entire community to experience this. Of course, when we think of the group being confined to a home, such as a nuclear family, certainly toxin exposure can be the sick house syndrome, the sick home syndrome, sick building syndrome. But when it extends beyond a family and it affects the entire community, there might be something else going on. And that may be the case, but then the next question is, does Walt Disney give us anything in the film to suggest what that actually is? It's a tough call. Right, so that's to be determined. If you're thinking more towards an individual case, if you're looking specifically at Aurora, what drugs are you concerned about? You mentioned that she looked like she was in a trance. What drugs are you concerned about? LSD, right? So any hallucinogen certainly would need to be in a differential diagnosis, and that includes the psychedelic of LSD. Yeah.
I was also thinking along the lines of, because she goes into deep sleep with coma. I'm sorry, I don't know the generic name, but the date rape drug, because she doesn't seem to respond to external stimuli. It seems like she loses memory. So I was thinking along the lines of that for the substance.
So it could be gamma hydroxybutyrate or GHB. So it could be a date rape. Matter of fact, a very unfortunate variant of this is the original story, which I believe was as early as the 1300s, where during the coma, she's raped and she bears a child. Right, so you're not far off here. Right. Oh, again, the original story. Yeah, deep sleep upon getting pricked with a needle. You've got to think opioids too, right? That's in a differential. Benzos can be, certainly. Again, if the Princess Kiss, again, apostrophe S kiss, is metaphorical for that's not naltrexone. Actually blanking on the anecdote. Nope. I'll get. Yeah, it's not fluphenazine. That's an antipsychotic. Flumazenil. That's it. Yeah, it's a word that sounds way too close to the antipsychotics. Flumazenil, metaphorical. Then sure, benzodiazepine overdose. Sure. Yep. So one question here would be, again, you can't dismiss GHB because of what this film is based on. By the way, what other film maybe we would consider it then a remake of Sleeping Beauty has the heroine, pardon the pun, bear a child during coma incident to, well, with her also getting raped. It's Kill Bill. Yeah, it's Kill Bill. Right? It's Kill Bill. Now, Beatrix is raped during her coma, but it's after she delivers the child. She was pregnant before she entered into the coma. Not the case with the 1300 original Sleeping Beauty motif or myth, but similar context.
Well, with Sleeping Beauty, it does occur like the day after she meets the prince, so maybe further clue of like, oh, he is instigating in a way.
Interesting.
Good point in GHB. Mm-hmm. The first time she meets a man.
Yeah, well, yeah, hey man, really, yeah. It's a good pickup. I missed that one day after. We do need to talk with him. I do want to send her this, and again, I think the GHB is something you have to very closely look at. Unlike GHB and other forms of date rape drug, which is usually put in their food or drink, she pricks her finger. And that may be more consistent with opioid overdose. So let's talk about opioids today. Let's talk a little bit about opioids and how Sleeping Beauty may be a fictional case of coma due to opioid overdose, heroin overdose. Focusing on that spindle, that needle. With acute opioid intoxication, you have to remember the pinpoint pupil. That well over 90% of cases should cue you in as to the etiology of a drug overdose being due to opioids. For example, heroin. This takes place much more commonly, that is a much more common outcome when benzodiazepines are also abused. Right? The respiratory depression that results from the co-administration, whether medicinally or whether recreationally, lends to significant risk of overdose and respiratory depression and death. On the other hand, with regard to the pinpoint pupils, you should know that there is a medication due to its anticholinergic side effect, dilates pupils. So what is this outlier? What medication is this?
Is it opioid?
It's an opioid, yeah.
Methadone.
Yeah, good, Methadone, right? Otherwise, brand name Demerol. Now, in clinical practice, 90+% of the time, that's not going to happen. Unfortunately, on an artificial shelf exam, 50-50. So remember Methadone, because either your test writer, the person who's writing your question, is either going to use Methadone or they are not. It's a 50-50 proposition. It is going to be incredibly different than real life experience, in which the vast majority of opioid overdoses present with pinpoint pupils and allows usually the emergency medicine physician to identify the source or the etiology of the overdose rather quickly. Hence, naloxone upon entry. There are additional signs and symptoms of opioid overdose. So if you miss, for whatever reason, pupillary size, which can happen, and again, the pupils being pinpoint are a necessary, that is a required diagnostic criteria. You need pinpoint pupils plus two of the following. Again, the pupils will not be pinpoint. You can ignore the requirement if Methadone and if comatose, right? If the patient's comatose, the brainstem being compromised may result in blown pupils, which will override heroin's effect, the opioid effect. Attention and concentration can be impaired in addition to the coma or altered state of consciousness. And slurred speech. Those are the common DSM criteria.
Does the DSM include things like
No, the DSM talks about mental status change, including coma, as an altered state of consciousness, but doesn't get into any of the autonomic dysfunction, not the DSM. So again, it's coma or another example of an altered state of consciousness. Attention, concentration, memory, cognitive deficits, and then speech, slurred speech. If not an overdose, but if your patient is using the substance and you miss this on a screening exam, admit the patient, they can actually go into fluid withdrawal while they're in the hospital, even though they're in the hospital for something different than their opioid use disorder. So screening for drug substance use disorder is part of a routine history and physical. And if your patient screens positive, what is referred to as the structured clinical interview, aka the diagnostic criteria, referred to before, but taking it from alcohol use disorder criteria and simply substituting opioid use disorder, that is the criteria for opioids. Same exact criteria, right? Again, use of a substance when, despite knowledge of adverse outcomes, during physically hazard circumstances, etc. Same diagnostic criteria. In such cases, you can implement what is referred to as the COWS protocol. It's the Opioid Withdrawal Protocol, COWS. And that protocol primarily looks at onset of symptom triggering a specific therapy. So if diarrhea, then Lamodal. Okay. If insomnia, then Trazodone. Right. So there's up to 7 of them. So before we get to COWS and before we get to actually treating opioid withdrawal, we have to first define opioid withdrawal, right? So opioid withdrawal, like any withdrawal, is generally defined as a substance-specific syndrome that results from the absolute or relative cessation of a substance. In this case, it will be opioids. Depending on the substance of use or abuse, there are going to be defining and specific withdrawal symptoms. What do the withdrawal symptoms of or from opioids look like? Oh, everybody spoke at once. I'm sorry. They look like the flu. Okay, they look like the flu. If you see a flu on any psych shelf exam, it is opioid withdrawal until proven otherwise. If you see the flu on any midterm exam written by a psychiatrist, it is opioid withdrawal until proven otherwise. I don't care if it's flu season. I don't care if it's in the vignette that the patient refused the flu vaccine. None of that matters. It's opioid withdrawal until proven otherwise. The acronym to remember opioid withdrawal is TGI Fridays. For exams, you almost never need to know the number of criteria needed to make the diagnosis. In this case, the T does stand for 3. So we're talking 3 of the following. And I state this not because you really need to know it for exam taking purposes, but it just fits the acronym. Nobody goes to a restaurant called GI Fridays. GI, nausea, vomiting, diarrhea. Clinically, if your patient has nausea, vomiting, and diarrhea, you could count it as 2. But GI stands for GI, nausea, vomiting, diarrhea. Fever, rhinorrhea or lacrimation, insomnia, dysphoria, arthralgias, yawning, and sympathetic nervous system, right? So diaphoresis, sweating, tremor, goose flesh, elevations in blood pressure, pulse, sympathetic. Any one rules in. 3 or more, you diagnose opioid withdrawal. And now we'll talk a little bit about therapies. Before we get to the treatment of opioid withdrawal, any thoughts on Aurora, on Sleeping Beauty beyond her being comatose? We're good? All right, so let's go with the therapies. 2 general forms of therapy. One is substitution therapy, and the other one is symptomatic therapy. Symptomatic therapy we already considered. That's called the COWS protocol, right? That's the 6 or 7 medications that are put on PRN or as you need it for any specific symptom that breaks through. Substitution therapy is providing a medication that has the same or similar mechanism of action as the drug of abuse, in this case, the opioid. One example of a medication that will do this is methadone. Methadone has a half-life of 24 hours, much longer than the half-life of heroin, and can be dosed daily or twice a day. Generally speaking, the ballpark starting dose would be 30. If the individual is provided a one-time dose of 30, and later in the day you walk into their room and they endorse 3 or more TGI Fridays, you will adjust the dose. You'll give them another dose. You walk in the next morning, you again provide the assessment, TGI Fridays, and you will then determine what to do with further dose adjustment, either increasing or decreasing. The general practice is that once your patient is stabilized, that is, they no longer endorse any signs or symptoms of opioid withdrawal, you reduce the dose by about 10 milligrams daily. Now, you could apply this not only with methadone, but with other mu opioid agonists, including those that are partial agonists, like buprenorphine. So the same applies to buprenorphine, which also binds that mu receptor, also binds to that opioid receptor, but once bound, only activates at about 50%, whereas methadone is a full agonist, meaning that it activates the mu opioid receptor 100%. But either work here. In either case, as you're tapering down the medication, there's a couple things to consider, and that is, what would your patient prefer with regard to aftercare? Because treatment of their addiction is not going to stop upon hospital discharge. If your patient agrees to accept the disease model for their addiction, for their illness, then you're going to recommend that the methadone be tapered and discontinued. And that would include the same for the buprenorphine. There is evidence to suggest that the taper should be protracted and should not be complete in the hospital. That people who actually have a more prolonged taper, weeks to months, as an outpatient, so discharging your patient maybe on that 30 of methadone to be tapered over subsequent months by their outpatient provider, lends to better outcomes. But in either case, the goal is to be drug-free. The goal is to be abstinent. The goal is to work a recovery program. On the other hand, if your patient tells you that they instead embrace the harm reduction model, then consideration should be given to referring them to either a clinic or an outpatient office that will continue to prescribe the opioid on a daily or monthly basis. Options would include discharging the patient on methadone and having them follow up with a methadone maintenance clinic so they're maintained on their current dose indefinitely. This is a daily clinic visit, Monday through Friday, in which they are provided their dose of methadone. On Friday, after they receive their dose of methadone, they're provided 2 take-home doses for Saturday and Sunday to return back to clinic the following Monday. Individuals who attend a methadone maintenance clinic have about the same success rate when we look at the clinical outcome of relapse, about 30, 35%, up to 40% relapse, traditional disease versus harm reduction through a methadone maintenance clinic. So outcomes are similar. Where there is clear benefit for those who are part of a methadone maintenance clinic is where there's decreased criminality and decreased hepatitis B and C and HIV transmission. So managing them on their dose of methadone daily certainly can lead to positive outcomes. The other idea is that this is part of a biopsychosocial treatment plan, so that while you're focusing on the biological through a methadone maintenance clinic, psychosocially, they're also attending school again because there's a lot less effort to secure their drug. They're getting a degree. They're joining the workforce. Methadone can only be prescribed in the way I described. That is Monday through Friday through an FDA and DEA sanctioned clinic. So you can't open up a clinic. We can't open up a clinic and partner in business and call our little storefront a methadone maintenance clinic and begin to dispense methadone. That's not the way it works. It's got to be FDA and DEA sanctioned. An alternative would be to discharge your patient on buprenorphine. Buprenorphine is often changed over to Suboxone during the hospitalization when this is the chosen route of aftercare, when this is the discharge planning. Because buprenorphine does have street value. It is an opioid, albeit a partial agonist. Suboxone, on the other hand, contains an extra constituent, naltrexone, which is a mu-opioid antagonist. And by adding the antagonist to the buprenorphine, you prevent the individual from crushing and then shooting or shooting, injecting, or snorting, because then the antagonist will be activated. There's going to be little effect, and therefore there's little risk for diversion because of the lowered street value. Suboxone, unlike methadone, can be prescribed office-based. Individuals, prescribers, can actually go through a brief training and get a Suboxone waiver and provide office-based maintenance therapy for opioid use disorder. So be very careful when we talk about buprenorphine and we talk about methadone. We're talking about two medications. One that's a full mu-opioid agonist. The other one is a partial agonist that can be both used in the inpatient setting for withdrawal as well as the outpatient setting for maintenance. And those are two very, very different treatment plans, albeit with the same medication, right? And that is substitution therapy. One of the clinical pearl is not likely to come up on an exam, but if your patient is going to embrace the disease model, AA and NA are likely going to be part of that. And in as much as they are, do not be surprised and continue to be supportive to people who may have abused heroin but prefer Alcoholics Anonymous. So there's nothing specific with regard to those groups. Some people find the type of element more conducive to their personality and therefore opt for AA, even though their drug of abuse happened to be heroin. Questions about opioid intoxication or opioid withdrawal or the treatment of opioid withdrawal?
So for the harm reduction model, would the AA and NA meetings not be sufficient compared to the disease model?
Generally speaking, no. It's not something that I would necessarily recommend. However, again, human behaviors, doesn't fit into a nice square hole on every occasion. So if your individual patient thinks that they still get something out of those meetings, even though they're clearly the cornerstone of the traditional model, the disease model, you should encourage their participation. Because one of the things that certainly they can contribute and even get out of with regard to attending AA or NA, despite being harm reduction, is they can tell their story. And their story may inspire someone who maybe is at the pre-contemplation stage to get to the action stage. So, and we should never discount that. Any other observations as we move away from Aurora with regard to any other characters in Sleeping Beauty?
I thought Maleficent was pretty interesting. I mean, to me, like, I guess she seems like pretty callous and like seems pretty ruthless in terms of her actions. But then I guess like it would be interesting like if we're taking into account the prequel versus like not just the movie as a standalone, because she seems like it's pretty like if you take the prequel into account, she has like a vendetta against their family versus just like as a standalone. That would kind of change her differential, I feel like, for her.
Yeah, and they've even tried to go by the route of a more recent film where they went the Wicked route and painted her as the victim, which was just a little bit of a miss, but wasn't.
And one, I didn't really understand why she was doing what she was doing.
And what?
There seems to be no point in putting a curse on the daughter for Maleficent. Putting a curse on the daughter, just trying to chase her for 16 years. So I didn't really see a point in that. I thought that was a little psychotic.
Yeah, as pertaining to this movie, I think that's a barometer of how victimized she felt she was not being invited. So again, when we talk about the narcissistic personality, the individual who believes they are special and could only be understood by someone as special as they, boy, this would then be the definition of narcissistic injury, right? I mean, times 100. Putting a curse on a baby so that she dies at 16 years of age when she's to become a woman. So, again, my thought would be to start with the narcissist because of that single criterion. Why wasn't I invited? Right? I mean, taken to the nth degree here by Disney. Now, again, we have to always be careful because implicit in this very discussion is the need to rule out a larger disorder. Right? We wouldn't, even as over the top as this is, we still wouldn't use the word narcissism if we believed it was part of a major depressive disorder versus a bipolar affective disorder versus other. So we still have to keep that in the back of our minds.
Well, she's like pretty grandiose. I mean, she calls herself like the mistress of evil, and she also notes that she hasn't slept well for 16 years when the prince is like locked in the castle. So that might suggest like an underlying bipolar disorder.
I agree. So I always ask this question when somebody brings up an observation like that. Is there any part of this movie that shows Maleficent digging, planting? Yeah, me either. Because dig fast happens to be the acronym that everybody remembers to learn the DSM criteria for mania. And what a metaphor that would be.
The
So,
only thing though is like the thorns, like she does put the thorns around the castle, like when she becomes the dragon. So it's not exactly like digging, but it's kind of like planting.
air quotes, planting. Yeah. Other thoughts, other characters?
I found the prince's father to be kind of interesting. I mean, I hadn't taken it far enough to like think through any actual like diagnosis that it would align with, but like he's quite confrontational. Like, you know, anybody that he has shown to interact with, he gets in a fight with, like the other father and his son. So I don't know. Something about him just seemed a little bit off.
Mm-hmm. Yeah. What's his current station? What's his current role?
He's another king, like of a different area, I guess.
Yeah. So
But
look.
he seems to not like feel very secure in his position at all, and like he's trying to like get the most out of everybody that he can. He's trying to like get the most out of the other father by saying like, oh, you should build them a castle, and then like he's trying to get things from his son. Like, oh no, you have to do this because I need the connections, and I need like everything seems to be about him.
Yeah, I think this character's role for us in our didactic, I think, is best served by looking at whether we even want to consider this to be abnormal behavior. Remember, in previous discussions, I had made the comment that as a clinician, irrespective of your patient's chief complaint, and this is in psychiatry, irrespective of your patient's chief complaint, we should always give them the benefit of the doubt and suggest that what they are telling us is normal until proven otherwise, all right? And normal here is really statistical. That is this behavior part of culturally sanctioned beliefs? Because if the answer is yes, there may be nothing to do. He's a king. Now, it's hard because, again, we don't have the prequel. He may have had these attributes prior to becoming king, and they may have certainly helped him to get to the level that he's currently at. So, chicken versus the egg. But at least the starter case formulation, is this normal? Because he is a king.
I guess it's just the contrast between him and the other king, Aurora's father. Like, Aurora's father seems much more empathetic. Like, when, like, they're supposedly good friends, but, like, his daughter has been gone for 16 years, and this is the day that she's supposed to come back, but, like, it's not like he's been in communication. Like, he's worried she might not come back. And then this is supposed to be his best friend, but he's just sitting there eating. It's like, oh, don't worry about it, whatever. And then he's like, oh, well, you know what? They actually need to get married, like, immediately. And he's like, well, she is still kind of young. And also, this is her first day back. Maybe we don't need to push that right at this moment. He just, I don't know, he seemed really lacking in any amount of empathy.
Mm-hmm. So your observation, I think, is right on here in that just because you're king, that's not sufficient to then explain, much less justify his behavior, as evidenced by other kings being quite noble. So now we're getting into a little bit of a trope, right? There are kings that are noble and there are kings that are not. For those of us who have watched Game of Thrones, the whole mythos is based on that idea, right? King of Thrones. So that's the general idea. Having said all that, if we still want to operate along this continuum in terms of how we want to kind of unfold our thinking, our case formulation, after we hypothetically say that this is normal, we still have to ask ourselves the question, is this disordered? Because whether or not we say it's culturally sanctioned / normal or not, if it is clinically impactful, there may be work for us to do. And that might be the case. What you're picking up on with regard to this innobility, if that's a word, may be this idea that there may be some functional impairment here, self or others. And if that's the case, then we have to consider, well, is the reason for that a mental disorder? And, we always get back to this idea of narcissism. And what you brought up, and I don't want to pathologize this cartoon character's behavior, but I do want to use it to put forth a major teaching point. And a teaching point for this particular case, with regard to what we identify as your observation was that he had incredibly poor self-esteem. And that's what I want to focus on here. And that's whether or not we really agree that he's a true narcissist. If he were, we should know, and we brought up this idea of narcissistic injury before, that individuals with this condition have incredibly low self-esteem. That's the etiology of the narcissist, low self-esteem. And as a result of their low self-esteem, they compensate by these behaviors that tend to be highly reliable. And over time have been identified as DSM diagnostic criteria, right? So low self-esteem ultimately results in that cardinal trait of believing they are special and can only be understood by somebody as special as they, very arrogant, very haughty. Right? It's the cardinal trait. So he may not rule in for narcissistic personality per se, But certainly, we'd have to consider it at least because of his incredibly low self-esteem. And we know that's very consistent with the etiology of this condition. Any other thoughts?
I was going to quickly add for autism, take it back to like the 7 about like the deadly sins.
Mhm.
How like narcissism with envy. And I guess you could argue that Upson had envy of the family. I know she was saying that she was mad that he didn't invite me, but everyone else. But that could also be she was envious of not having all those friends and having all those people like be there with her and be a part of everything, be part of the whole kingdom.
So it could be. Yep. Envy could have played a major role with regard to Maleficent. Yeah.
This may be somewhat unrelated, but when I was watching it, I was reminded because we watched Hocus Pocus recently for one of our other didactics. I was kind of reminded of the trio of sisters, like the witches, and then the trio of the fairies. Some of the dynamics, there were some similarities there. Like the tallest one was the one that was the most in charge, and the other women like really fell in line kind of underneath her. And then there was another one that was like the kind of shorter, heavier step sister. And then there was another one who was a bit more flighty and kind of like in her own world. So it was kind of funny to see the good version of like the Hocus Pocus trio that we talked about.
Interesting. Yeah, they do match up quite well, don't they? Yeah. Yep. And again, very similar to the king, good king, bad king tropes. So too are the fairies / witches tropes, as you described them.
And like in Hocus Pocus, they were very maladaptive in their relationships, but then in this one, it was a bit cuter. Like yes, they kind of relied on the older ones, but it wasn't in so much of it. She didn't boss them around in the same way. Like she was in charge, but it was sort of that they like respected her opinion often and kind of went with it. And even if they ever kind of acted up like with the blue, pink battle, it was a healthier version of the Hocus Pocus sisters.
Yeah, I agree. It's a good pickup. All right, well, we will end this discussion here. Again, this was a brief review of opioids, opioid use disorder, intoxication, withdrawal, and the treatment for opioid use disorder, including withdrawal. I will post the acronym TGI Fridays on Instagram later this afternoon. Okay, so I will get out as early as tomorrow. Next week's films, I think they're going to pretty much be the same that are currently posted for you on AMP, but just to make sure, I will repost over the weekend to make sure. I did post something on Twitter a couple of days ago for purposes of this group. I know that usually it's 3 movies. If you're dividing it up, perfectly fine. As long as the group has all 3 covered, nobody has to watch all 3 films. When I give a film that I really want you to watch, like 7 because of the conspiracy theory discussion, I'll make special note of that. But otherwise, dividing the films up shouldn't be of any adverse consequence to us, right? All right. So then tune in next week. I'll see you then.